الله الرحمن الرحيم. نبدأ. This presentation is dedicated to my father, who taught me everything, and the last case was following up at his clinic for years. First, don't miss the presentation Pentacam by Dr. Reem and Glaucoma by Dr. Amr and OCT retinal nerve fiber layer by Dr. Kamal. You have to see these presentations to understand the point of view that I'm trying to deliver. Glaucoma and glaucoma suspect in keratoconus, keratoconus suspect and first keratoconus. As an introduction, can we really define glaucoma precisely? It's really difficult to put a precise definition. But there is progressive optic neuropathy, there is field loss, and the intraocular pressure is a key factor, and luckily it is modifiable. History that the glaucoma is increased intraocular pressure, this is wrong. I remember my professor, Dr. Hussein Suilam, he says, if you say glaucoma, then this is a death sentence to this optic nerve. You're telling this patient, your optic nerve is going to die someday. So be very cautious when using this word. If you say glaucoma, then you have to be sure. So scientists rely on this triad: intraocular pressure, disc changes, field changes, and here we have to say that the disc changes should correlate to the field changes. Not any disc abnormality, any disc that doesn't look well, and any field changes, we just sum them together and say it is glaucoma. No, they have to correlate somehow. It has to be glaucomatous field changes, glaucomatous disc changes. Okay, how to measure real pressure? I remember Professor Kafrawi, he says the only way to measure, you have to put the pin in the tire and measure the intraocular pressure or the pressure inside. So what we are doing is we are trying to measure the tension, intraocular tension, by the Goldman applanation tonometer. Whatever the device is, you press from the outside with a force, and then when flattening happens, so we assume that the pressure is equal on both sides. I don't know if you're familiar with this device, but I have used this device actually a couple of times. I think it's called Troit's tonometer. Air puff uses the air to flatten the cornea, and the infrared emission light says this is flattening and gets the intraocular tension or whatever. Okay, so the assumption here is that all the eyes has the same thickness, but actually this is not true. If you get a balloon, you would put a minimal pressure to get flattening, but actually the pressure inside is high, it may explode or something. While a basketball, you could put very big pressure and the tension inside is almost zero. It is almost, there's no air inside, because the thickness is different. The balloon is very thin, while the basketball is very thick. But the question is, so they did this table. Dr. Reem provided me yesterday with the reference, but I couldn't put it. But anyway, it says that if the cornea thickness is 540 or something, this is 0. If it is more than that, you add, you subtract. Less than that, then you add on the intraocular pressure measured. But is really thickness has anything to do with stiffness? You have like this 50 centimeter mattress, soft and comfortable. Is it really stiff as only one centimeter thick steel sheet? No, definitely not. So this is what I'm trying to put in mind. We want to put the Pentacam as a substitution to the sensor corneal thickness, because the thickness is not reliable. Okay, the first case I've met was 2 years ago, mid-40s, patient coming for reading glasses only. So his hypermetrope plus 1.5, okay, intraocular pressure good, 14, but I've seen cupping, a deep cup, 0.7. For my knowledge, hypermetrops, usually it's a crowded disc, 0.1 cupping or maybe full disc. What does this have to do with anything? So I did the pentacam. This is the disc. I want to ensure again, I'm not here to argue about if this patient is glaucomatous or not, is this rim is good or not. This is not my specialty. But to somehow, it looked suspicious to me, and I did the, by the way, this is the central corneal thickness, 530. 530 is more or less normal. So if you use that, it's going to be like 15 intraocular pressure. That's nothing. This is the pentacam of this patient. This is what we call form thrust keratoconus. Maybe this patient, if he came early in life, 20s or something, I would say he's a keratoconus and doing cross-linking directly, or wait for 6 months to prove progression and do him cross-linking. As you can see, the thinnest location is only 500 or 490, while the central cornea thickness as measured by the eye master is 530. And this cornea is not stiff enough, so you cannot measure the intraocular pressure. And this is the other eye. And doing this OCT retinal fiber layer, definitely it is suspicious. I'm not going to say it is glaucoma or not, but it's for follow-up. For sure, it is for follow-up because of the average cup disc ratio difference. Okay, the field was normal. After 2 years, maybe there's some changes. I'm not going to argue if you're going to take anti-glaucoma drops or not. Maybe some glaucoma doctor will give him anti-glaucoma drops. Some will follow up more, but there is some changes again. Okay, the second case, there was a post-aphasia case, not done here in our facility, but it came for cross-linking here. We did have the operation. She was satisfied. She said that her mother is glaucomatous and she's on glaucoma treatment, but not compliant with her. She did this central cornea thickness outside and the optic nerve. Anyway, in the other hospital, they suspected she's glaucoma and they gave her treatment. Surprisingly, her pentacam also is not good. I would see this case, I wouldn't do LASIK operation. Maybe if I'm a little bit risk taker, I do PRK or not at all. Once more, this is a 50 years old female. She's not here for refractive surgery. She gave history of glaucoma treatment and she was suspected as a glaucoma patient in other facility. This is one of the, let's see, not very famous signs of the anterior sagittal map. It's called Nazi sign or vortex sign. Once more, you'll have to revise the other presentations to illustrate this. Okay. The OCT, more or less suspicious. Are we going to give treatment or not? It is not my decision to make. I'm just trying to illustrate that take care. This low tension is not measurable. We are not measuring it correctly. Keep a close eye on this patient. The field was normal, but this is the optic disc. Definitely I would keep an eye on this patient. The father was satisfied. He wanted to do glasses too. There was nothing here really except the difference between the two eyes in the measuring intraocular pressure. He was like 75 years old or something. I did a pentacam just to see something else. Definitely keratoconus or form thrust keratoconus, but unluckily he refused to do any field or OCT. Okay, now I have excellent. during the routine examination, I found that there is cupping, and they are both, I think, hypermetrope too. So what's going on with the hypermetrope and cupping? I don't know what's going on. I did the topography. I have this topography in the facility. It was suspicious for me, so I sent them here to do pentacam again. It is called form thrust keratoconus, late 50s, pilot, intraocular pressure low, but there's something strange. The OCT, more or less, I'm not going to comment if it's suspicious or not, but the field too, I don't think this is something that's borderline. This one was done outside our facility. After 1 year, it was still normal. This field was done here. Okay, but he is suspect. The other case, also hypermetrope, plus 1.5. I did the topography. Very, very strange. Old patients look keratoconus, send them for pentacam. So if you do this patient, central cornea thickness is going to be 560. And this is not the issue. This cornea is not stiff enough. You are not measuring the intraocular pressure correctly. The OCT is suspicious. The field, I would say normal, borderline. But when we did this swab test, it's suspicious. Will he take anti-glaucoma treatment or not? It's not up to me, but he should be followed up, and you should know you cannot rely on measuring the intraocular pressure in this case. Not with the CCT table, not whatever. An old friend in a dilemma years ago, actually this was one of the cases at my father's clinic. Is he glaucoma or not? This was maybe his first visit at my father's clinic, maybe 2006. So it was maybe suspicious cupping, 0.6, 0.5, tension not that much. The following visit, my father ordered a field and OCT. More or less it was normal, but he did one, I think it was in France or something. It says that it is suspect case, glaucoma suspect based on asymmetric cup to this patient. So only defined as a suspect. Tension is 16 without treatment. This is the OCT. I think this is suspicious for glaucoma. This is the field. Definitely I would let him take anti-glaucoma drops. This is really, and this is the pentacam. And there is backfloat and there's the tongue configuration. So definitely this pentacam is not good for LASIK. So it is not stiff enough, and this pressure is not good. You should give this patient anti-glaucoma drops, whatever the intraocular pressure is. The worst fear that these cases get neglected because the tension is really deceiving, 11 and 12 and stuff like that. This patient came for refractive surgery. Actually, it was a very small error. I told them, don't do anything. The right eye is perfect, only half diopter astigmatism, and it's from 0.8 to 1. But we can definitely do something for the left eye. It's from 0.1 to 0.9. So it seems that this astigmatism is really good. I did the pentacam. It's possible keratoconus, and then I did these cases get neglected, that it develops then 29, then 34 in the left eye. This adds that you cannot measure the tension in these cases correctly. This was one of the last minute cases. Just regular follow-up, nothing hypermetrope again. I don't know what's wrong with this hypermetrope and cupping. And this, I wanted to show you this picture alone because, to be honest, if I have seen the Pentacam, all of it, I would do LASIK for a case like this. I don't put in this minimal skewing, this Nazi logo. I don't give it that weight in my practice. Really, I would have done LASIK, not PRK or something. But I think after this, I'm going to consider this sign as something. It's really very thick cornea, so not that evident the skewing and the Nazi sign, but it's glaucoma terribly case. This is the field. So again, we are not measuring the intraocular pressure correctly in these cases. This was the idea I wanted to illustrate in this presentation. I have read on new techniques on measuring the intraocular pressure in keratoconus. Relatively new. Actually, my master's essay, I was familiar with the ocular response analyzer, the ORA. But anyway, to give like a brief ocular response analyzer, it's like the air puff, but it gives two measures, two spikes, and there is the reaction of the cornea, and then they say that this cornea is rigid or stiff. There is the dynamic, the corvus, it also depends on air, but although both are air puff, but they are different in measuring the corneal biomechanics. There is something called the dynamic contour tonometer. I don't know exactly the mechanism, but it is said that it's the most accurate device to measure intraocular tension in keratoconus. I don't know that's available in Egypt or not, but again, it is not the issue. What I'm trying to say is, when they did this paper actually is interesting. They are evaluating the Goldman attenuation tonometer and the rebound tonometry and the DCT in keratoconus. Again, I want to say, there has been papers on this stuff, but I am saying we should do studies the other way around. Don't try to measure the intraocular pressure in keratoconus. I want to go the other way around, not measure the intraocular pressure in keratoconus, because actually this is established. You cannot measure it. Okay, this was a last minute paper Dr. Reem provided yesterday. It seems that this idea was a long time ago, but it wasn't popular, that there is a relation between keratoconus and normal tension glaucoma. I wasn't aware of this paper till yesterday, but there is advantage of what I'm saying. In this paper, they used the corneal topography to do the screening or diagnosing the keratoconus. Corneal topography and central corneal thickness. Most of the cases wouldn't have been like that because they rely on the Pentacam. So they would have missed some of the cases. What I'm trying to say, first of all, don't skip any part of the examination. If I have skipped a fundus examination and LASIK cases, most probably I have done LASIK to cases suspicious like those. And number two, that the Pentacam may replace the central corneal thickness in glaucoma evaluation. It should be done as the glaucoma portfolio. It should be added. Central corneal thickness is not that accurate. I have illustrated cases with 560 micron central corneal thickness, but they're keratoconus, and you cannot measure the intraocular pressure or rely on it. And we should work hand in hand. Also, this is a message for refractive surgeons. Please do field and OCT retinal fiber layer for all keratoconus and keratoconus suspect cases and from thrust, because you could give these patient medication. You could put them on anti-glaucoma and save them a disaster that I think there's 2 cases that I've illustrated are really bad. Finally, I would like to thank Dr. Nawara. He supported me along gathering these cases. Thank you very much.